Welcome, everyone. Thanks for joining us. Okay. Well, we have a few more people kind of filtering in, but I will get started with our introduction. We have a great session today, so appreciate everyone coming on. So I'm Kelsey. I'm the program manager with MathNet. And today I'm introducing Dr. Drew Komen, who's here to speak with us about neuropsychological assessment and school supports for youth experiencing psychosis. Dr. Drew Komen is the Director of Child and Adolescent Psychology and of Neuropsychology at the Psychosis and Clinical Research Program at Mass General Brigham and Harvard Medical School. He received his undergraduate degree at the University of Miami and also completed his graduate studies there in child and clinical psychology. He concluded his training with a predoctoral internship and residency and postdoctoral fellowship at MGH and Harvard Medical School. So he's been a faculty at MGH and HMS since 2014. Dr. Komen has training and expertise in conducting comprehensive neuropsychological and educational evaluations for a myriad of neurodevelopmental disorders, major psychiatric conditions, as well as learning and language-based learning profiles. So comes to us, I think, with a lot of background in this area and hopefully some pearls of wisdom to share. So thanks, Dr. Komen, for joining us today.
Thanks so much, Kelsey. And thanks for everyone for joining today on a Friday afternoon. It looks like we got a robust crew here. So I know Friday afternoons are not easy. So I appreciate everyone being here. Yeah, thanks for the introduction. And so obviously I have some slides prepared today, and we are scheduled to, I believe, so Kelsey, 1 o'clock, right? So I want to be mindful of everyone's time. I'm not, hopefully not talking until 1 o'clock, and we'll have a lot of time on the back end of this to, just to kind of chat about any particular cases that come up that have come up for you, or navigating schools, and I can give you my 2 cents with that, and we can bounce ideas off one another. And then post this too, I am more than happy. Feel free to contact me, and I'd be more than happy to provide any sort of curbside consults and things of that nature. So, but without further ado, I'll pull things up, and we'll get rolling here. And it looks like my colleague Martha Humphreys is here. All right, Martha. So Martha is our supported and educational employment specialist in our FEP program. So her and I work closely together with all of these accommodations. So thanks for coming, Martha. Appreciate it. All right, so bear with me as I get some things dialed up for us. Okay. All right, and Kelsey, if you want to just give me a heads up, if sometimes when I do this, the slides don't turn, so and I just keep talking, and so just give me a heads up if things are not looking as if they're not following along with what we're discussing.
Great. Yep. No, we see the title slide.
Okay, great. Excellent. Excellent. All right. All right. So yes, today we're talking about the utility of neuropsychological assessment in psychotic spectrum disorders. I think we are going to talk about the utility and also some of the pitfalls too. So I'm a clinical psychologist, neuropsychologist, as Kelsey introduced, and I work in the MGH, MGB FEP program, or really in the psychosis and clinical research program, kind of in many different branches of that program. And so we're going to be talking about how I believe neuropsych testing can be helpful for the folks that we work with psychotic spectrum disorders, and also talking about the limitations of it too, which I think is really, really important, is that we understand the limitations of the snapshot of neuropsychological testing that occurs for our folks, and delineating profiles of strengths and weaknesses. Okay, so today, if you don't already have one, I'd like you to leave today with a basic working knowledge of what we know about neurocognitive functioning in psychotic spectrum disorders. I'm assuming there's kind of a range of experience with neuropsych testing, so I try to do some low-level fundamental things as well as kind of higher order things and everything in between. But the goal here is just to really kind of have a basic working knowledge of what we know today and what the extant literature tells us. And then become more knowledgeable of utility and best practices in neuropsych testing in psychotic spectrum disorders. And those best practices, again, speaks to kind of what are the pros of it and what are the cons of it, or what are the limitations and pitfalls we need to be aware of when it comes to neuropsych testing. And then really understand what is available to support our patients in the school or workplace setting. At the end of the day, I think whether you work in a clinical high risk program, a first episode program, or a chronic program that manages folks with primary psychotic disorders, I think we can all agree that an integral step in someone's recovery is getting their life back. And much of that, many times, that means getting their life back when it comes to education or when it comes to employment. And so, just to speak from our program, the MGH PCP or PCRP, is we really feel that that's a critical juncture and an important step in recovery from psychosis is getting those things up and rolling. And as we all know, those trajectories look different for our patients across the board. All right, so I promise you, I am not going to go into what is psychosis. We all know that. We're all kind of in this field here. But one of the things I just want to highlight is we all know kind of the primary symptoms and the other symptoms that are sometimes associated with psychosis. And we talk a lot about kind of the prevalence of it and really how common it is. But one of the things that's oftentimes missed, I think, whether it's within the clinical field and certainly within the community, and certainly with the patients and families that we work with, is this important factor of the cognitive deficits and or confused thinking that comes with the onset of psychosis. Psychosis is a brain-based medical condition. We can kind of think of it as your brain gets really stressed. It's kind of an insult to the brain. And that creates is kind of creates vulnerabilities in many of our folks, whether it either creates those vulnerabilities or it exacerbates pre-morbid or pre-existing vulnerabilities. And we kind of think of it as an insult to the brain. And it's one of the more important things, in my opinion, for us to kind of understand with regards to our patients and how they're functioning and their trajectory and recovery and so forth. Because while the hallucinations and delusions get all of the press, if you will, really the cognitive deficits and confused thinking is something that really holds our patients back from taking or progressing in their treatment or taking a road in their recovery that they want to take. And it's also educating the families, caregivers, and parents about that this is a condition that impacts the brain. It's a condition that really creates a lot of obstacles, even if the symptoms that get all of the press, like the hallucinations, get under good control, if not completely remediated with medications and treatment, that these cognitive deficits still linger and create a lot of difficulties for our folks. And B, it is not something necessarily that the psychopharmacological interventions are going to intervene on directly, right? This is something that there's a lot of rehabilitation that occurs from a cognitive standpoint that's important outside of medicine, even though the medicines are obviously incredibly important for many of our patients. Okay, all right, so going to start kind of very ground level about how I think about really kind of the dimensionality of psychosis spectrum conditions or psychotic spectrum conditions. And then how we kind of, or I think about that as we step into kind of neuropsych testing. So as I think we're all kind of moving towards this in the field, is that we understand all of these conditions is not categorical, right? The DSM-5 TR kind of handcuffs us a little bit from this categorical idea, but we very much know now from our clinical experience and what the science tells us is that everything really kind of has this spectrum, right? And we apply that to autism, decades ago, and it was coined by Lorna Wing, and we all kind of understood it of like, oh yeah, autism presents differently. There's a lot of heterogeneity in its presentation, and therefore we're going to now not call it autism and Asperger's. We're going to call it autism spectrum disorder. And I really think we need to apply that kind of same thinking and lens through all of our conditions, right? Anxiety, OCD, ADHD, and certainly psychotic spectrum disorders. And so, I kind of think of this from a very ground level up of our the folks that the condition that the folks that we work with are managing in this kind of spectrum light, right? And Dr. Stephen Shore kind of uh, has this really famous quote of, if you've met one person with autism, you've met one person with autism, just highlighting kind of the spectrum and variability of presentation. And I very much feel the same way when it comes to psychotic spectrum disorders. And then this is even the more accurate picture sometimes that we're disentangling, right? As we work with our folks and we're doing our initial assessments and providing treatment plans and programming and so forth, is the overlap and co-occurring symptoms and traits across all of the conditions, neuropsychiatric conditions that we work with, where we have these kind of overlaps of executive dysfunction and social deficits and challenges with repetitive and intrusive thought processes, et cetera. And so neuropsych testing really is part of it is really to help disentangle some of this. And it is best done, in my opinion, within a coordinated specialty care program like many of us work in, right? Our patients, the folks that we work with, are working with a psychiatrist. They're working with us as individual therapists or a neuropsychologist, family therapists, as well as supported employment educational specialists and peer specialists, certified peer specialists. So it really takes kind of everyone's kind of clinical lens from a multidisciplinary approach to really, in my opinion, get a really good understanding of someone's profile of strengths and vulnerabilities and to develop a really robust kind of treatment plan and follow through with that plan. So this is just kind of the developmental considerations of what we know across these conditions, that there's a lot of shared genetic risk factors and a lot of overlap. This just kind of doubles down on that slide before, just kind of the overlap that we see with a lot of these neuropsychiatric conditions. And also to take into consideration about the way in which I start to think about neuropsychology and its application to psychotic spectrum disorders is that really stress diathesis model that we understand all of these conditions in, right? And the reason that I put this slide in here is I think we all kind of operate in many ways with this understanding of why this illness develops. But one of the things where I think neuropsychological testing can be really helpful and critical is in this realm here, right? So if our folks, if we're working with a 19-year-old who had their first episode of psychosis and had to take medical leave from college or school, and then we have some treatment of their symptoms at some point, and they're ready to kind of get back into life, if you will. Our goal really as their treatment team is to keep this stress low, right? So we all have a biological vulnerability for psychosis. If you have a brain, you can develop psychosis, and we all experience some stress. Now, where we fall within this biological vulnerability realm is different for each and every one of us, to where the stress kind of turns on the psychosis or being unwell, if you will, versus well. And at the end of the day, what we can do is as neuropsychologists, is that we can't do a whole ton with the biological vulnerability piece, right? With the genetics are the genetics. But what we can do is we can help mitigate and decrease stress. And we can do that by way through neuropsychological testing as a complement to the treatment that's going on there. Okay. All right, let's see here. Okay. All right. The other way in which I want to kind of start, really kind of lay the groundwork in our thinking with this talk is really understanding psychosis, psychotic spectrum disorders as a neurodevelopmental condition. I very much think of psychosis or psychotic spectrum disorders as such. Many of our patients will have early neurodevelopmental things going on, and whether that's speech delays or motor delays or early intervention is involved for various reasons. So the data are more consistent really with a neurodevelopmental model when it comes to psychosis, kind of this fixed lesion from early in life which interacts with normal brain maturational events that occur much later. So when we think about psychosis, we very much think about, and this is Danny Weinberger's work on this, is we think that they're very early on pre-morbid, even before the prodromal phase of these pre-morbid kind of brain differences that oftentimes occur. And the psychosis actually is the late stage of this condition. And therefore, it's important from a neuropsychological standpoint to kind of really understand kind of what was going on pre-morbidly for someone that can be exacerbated by the psychosis and thereafter. Okay. I know there are some questions coming in here, and I will definitely get to those. I will definitely get to those here. I'm just going to get through some of this, and then at the end, I'll look through the chat and look at some of those questions that are coming in. But if there's anything critical, please let me know, and happy to stop and chat and take it from there. All right. All right, so psychosis kind of being the late stage of schizophrenia. All right, so one of there are many different areas in which we assess, and so there are areas of cognition and the area of social abilities as well as nonverbal social communication, which are embedded oftentimes within neuropsychological testing. And the reason that we are assessing for these areas is because this is kind of what the science tells us that's impacted in the context of the insult of psychosis to the brain. So really things like immediate verbal memory, so memory, your memory for like language or oral stories, social cognition abilities, your ability to kind of understand to and fro conversational skills or to pick up on nuances in social situations. And then also the nonverbal social communication stuff, which is oftentimes impacted too. One of those being one of the things that's a primary research arm within PCRP is Dr. Daphne Holt's research on personal space and how that differs in individuals who've experienced psychosis versus not. And testing can be critical even when a clinical high risk presentation is identified. So really, the extant literature suggests that even in folks that have not experienced a full-blown first episode of psychosis, that the CHR populations, the clinical high-risk populations that have these kind of smattering of symptoms that haven't quite met the threshold, but there are concerns with psychosis, that these folks are already presenting with discrepant neuropsychological profiles in comparison to healthy controls. So this is even prior to the first episode if a transition to full psychosis occurs. So we're already seeing differences in our clinical high-risk populations in things like working memory, verbal learning and memory, attention, processing speed, and executive functions, which is important because if we take a student, right, let's say a 16-year-old who is presenting with clinical high risk, they're already having difficulties with distress related to symptoms, right? They're in a high school setting. They are managing high school, the independence and coursework that comes with that, the social expectations that come with that. And now we're already seeing their neurocognitive functions starting to be impacted. And so the reason that neuropsych testing can be important in that context is that we can go in, assess those areas, and help that individual with getting accommodations or services within the school setting so we can mitigate stress as much as possible, hopefully preventing this to go on a trajectory of a first episode full psychosis. And so, this is where all the clinical high-risk folks in the room, the importance of the work that you're doing so that we can try to stave off the transition into full psychosis. All right, so I'm just gonna get into some of the data that supports that. And so this is looking at clinical high-risk population here. This is different areas of verbal IQ, perceptual reasoning. You kind of think of that as your non-verbal thinking abilities or your visual spatial abilities. So it'd be doing things like puzzles, logically reasoning to see how objects are related to one another in space, your verbal attention, your ability to attend to language, your ability to attend to visual information, and then different verbal areas, executive functions, motor functioning, and so forth. And what we can see is, so these are standardized residuals. We're going to look at the differences between the healthy controls and the clinical high risk population. And what we can see in that clinical high risk population based on the literature here is that we're already seeing differences in each of these key neurocognitive functionings or other areas of functioning in individuals with clinical high risk for psychosis. So again, an important consideration of that psychosis really being on the later end of the illness there. And that we're already seeing these challenges in neurocognitive functions, even in our clinical high risk population. So this is going to highlight the memory impairments identified in people at ultra high risk for psychosis who later develop first episode psychosis. So this is the healthy control. These are here. These are patients in ultra high risk group who do not develop psychosis, this kind of magenta line here. And then this is patients in ultra high risk group who develop psychosis. And this is mean IQ. And what we can see is kind of some pretty big differences pre-morbidly and kind of currently within that group. So this is after a 1 to 3 year follow-up here. And so the healthy controls, we can kind of see where what happens to that IQ really kind of stays largely, we would say that kind of stays stable across time. But we can see generally within the patients in ultra high risk, those who do not develop psychosis, and certainly those who do develop psychosis, we really see some neurocognitive changes that occur across time from pre-morbid to kind of current. This is really saying the same story, but this is for first episode schizophrenia. So we were talking about clinical high risk here. This is more talking about the first episode population here. And this is looking at the point of this slide and is to really look at the difference between first individuals who have had their first episode, so one episode, full-blown episode of psychosis, which by determination looks like, okay, this is the first episode of psychosis, which is likely going to be a primary psychotic disorder, versus individuals who have been managing schizophrenia for a long time, so chronic established schizophrenia. And the important thing here, or the interesting thing here, is that when we compare the first episode group with the established chronic schizophrenia group, and we look at each of these neurocognitive areas, these critical kind of neurocognitive areas, we, in a very worrisome way, are seeing that the first episode group is already presenting, and these are mean effect sizes here, they're already presenting with differences in their neurocognitive functions that are just as severe as the established chronic schizophrenia group, which tells us the importance of staving off first episode psychosis, right? So those in a clinical high risk program here, the importance of the work that you're doing in early identification and early intervention. In addition to that, it also highlights for us is that when a first episode occurs, certainly looks like the end stage of this illness from a neurocognitive standpoint, but how the impact of psychosis, a full-blown psychosis, the impact on the neurocognitive functions is markedly severe and important to consider as we think about working with our folks and developing treatment plans. This really kind of says the same thing. We are looking at, again, these are mean effect sizes, and we are comparing, this is CHR, this is not clinical high risk. This is a little bit confusing here, but this is actually in this particular article, CHR was established chronic schizophrenia group versus the first episode group. And this is pre-morbid to first episode. And what we can see is that pre-morbid, we can see that there's a big change from the pre-morbid functioning to the first episode kind of functioning. And then that's pretty comparable, again, to the established chronic schizophrenia group. So again, highlighting the importance of clinical high risk work, in addition to that, the impacts, the severe impacts of having a first episode of psychosis on cognition. Okay, So this is just to give us kind of a practical sense. I know I'm throwing out all these kind of psychobabble terms like verbal immediate memory or verbal fluency, vigilance, and so forth. But these are kind of the areas that are strongly associated with those. So, for example, we can see the strong correlation of immediate verbal memory and psychosocial skills, the community daily activities. So this article here just highlights that we're not just collecting data with neuropsych testing and saying, okay, this is where this performance is falling in immediate verbal memory. We've actually kind of translated that in someone's practical day-to-day life. Like, how does that impact their day-to-day, right? And we can see kind of the correlations there or associations between those. Okay. So now what we're going to do is so that's kind of the background, right? So, key points there are essentially that we understand psychosis and primary psychotic disorder certainly as a spectrum. We know that there's a lot of overlap. There's a lot of co-occurring or comorbid conditions that come with psychosis. We know that psychosis, when someone develops a first episode, we can kind of think of that from within a neurodevelopmental framework, that when psychosis rears its head in a full-blown first episode, that is really kind of the late stage of that disease, that there are kind of typically there are early pre-morbid kind of things going on, executive functioning deficits and so forth, that can be exacerbated by that, or the psychosis onsets those. And the reason that it's important to stave off first episode psychosis is that when that hits, there is a marked impact on neurocognitive functions that is equivalent or commensurate with what we're seeing in individuals who've been managing this condition of schizophrenia for a long time. And also, and maybe lastly, is we start to see those changes even within our clinical high risk groups of those that are kind of at high risk for developing a first episode. All right, so now we're gonna get into more of the kind of nuts and bolts of neuropsych testing and what we do and why we do it and how we can be helpful and how it applies to someone's day-to-day life of what do we do within the school setting or what can we do within a workplace employment situation. Okay, so we all operate a little bit differently, maybe in our clinics. I'm going to just give you kind of how we operate at MGB in the psychosis clinical research program, and the way in which, and then we, hopefully this either applies to kind of the way in which you all operate, or maybe there's some tidbits here that can be helpful, kind of understanding neuropsych testing. So one of the things that the assessment process, in our opinion, when it comes from a differential diagnosis standpoint, right? So is this a substance-induced psychosis? Is this an affective disorder with psychosis? Or is this a schizophreniform that eventually will lead into a primary psychotic disorder such as schizophrenia or schizoaffective disorder? The way in which we kind of tease all that apart is not by one snapshot of neuropsych testing, right? Neuropsych testing has limitations, in my opinion, when it comes to that. Unless we have really, really detailed records of someone's symptom presentation, and we have really great reporters from a patient standpoint, from a caregiver or family standpoint, sometimes we can do that. But the majority of the time, the way in which we operate within the PCRP is that we take a longitudinal assessment approach, right? We're working with our folks for months before we're really making that determination. My highlight of that is I am really wary when I get a neuropsych report, let's say from an outside provider that comes our way that says, the Rorschach said this and that and so forth, and this is schizophrenia. I have a lot of trepidation in taking that for its word when it's a snapshot, unless there's kind of this like really documented history of what this looked like. And so, from our standpoint, neuropsych testing has its limitations when it comes to disentangling kind of overall presentation. Really, a longitudinal assessment, in our opinion, is important. With that being said, during that longitudinal assessment process, neurocognitive testing can be really helpful. Neuropsychological testing can be really helpful. in delineating in a comprehensive way how someone's kind of brain is working and operating, and what are the strengths and what are the vulnerabilities. The big picture to neuropsych testing is we are really just mapping performances on testing, right? Certain paper pencil testing, working with blocks, time tasks, etc. We're mapping their performances on a variety of tasks onto areas of the brain and the associated functioning of those areas. That is our goal, right? And to kind of understanding how are the gears turning in different areas of language and spatial function, executive function, memory, and so forth, so that we can have an idea of how this person may be struggling and what we can do from a school or work standpoint or life standpoint to support them and help them out. All right, so common diagnostic presentations where neuropsych testing can be helpful. And this is where I feel a little bit, certainly more comfortable, than disentangling and saying, okay, this is, an affective condition with psychosis versus schizophrenia versus schizoaffective disorder versus substance-induced psychosis, right? So that, in my opinion, those kind of disentanglement, in my opinion, is best done through longitudinal assessment. With that being said, though, one of the things that neuropsych testing can do is come in and really do a nice job of evaluating for comorbid conditions, which can, in a snapshot in time, can be more clear with neuropsych testing. So these areas of specific learning disorders or language disorders, ADHD, NVLD, and these other kind of comorbid mood disorders and so forth that can occur, including autism spectrum disorders. So the reason that neuropsych testing can be helpful to this end is that if we identify this, let's say, for example, it is not uncommon for me to meet with someone that's been in our, that enrolls into our program, they get neuropsych testing, and we identify, oh my goodness, this is a 9th grader who historically has had challenges reading. School has been really stressful for them, caused a lot of anxiety, maybe even school refusal. And then there's been social difficulties due to that. And, eventually this culminated with all the other stressors going on in their life of a first episode of psychosis. And many times what we are doing is we are identifying, something like a specific learning disorder of patient A has developed psychosis, but has gone through school up until 9th grade with this specific learning disorder, let's say dyslexia, that made learning really challenging. So we unfortunately went unidentified this long, but now that we know that it's there, what we can do is we can really educate the school team about, hey, when this individual integrates back into the school setting, their brain works a little bit differently, operates a little bit differently, is going to need some intervention when it comes to kind of the reading and so forth when they're ready to kind of do that, when they're ready to get back into the curriculum. Okay. So we won't get into necessarily the ins and outs of dyslexia, but just something that we're doing with neuropsych testing. So another bird's eye view of way in which I think about this is, as we are evaluating for someone's neurocognitive profile, strengths and weaknesses, and all those different areas that we talked about, or that we are evaluating for, oftentimes I'm getting a referral for neuropsych testing where their treatment providers say, hey, like, we think there's maybe an autism spectrum disorder going on here, or can you rule out ADHD, or can you rule out any of these specific learning disorders? And the way in which, our job as neuropsychologists is to really think about, where the diagnostic threshold for those things are in the context of there being a lot of overlaps of traits, right? So if we think of this XY axis as the X-axis here being symptomatology of whatever we want to think about, let's say symptomatology of autism spectrum disorders, for example, right? We have 0 to 100 or severe, okay? And really, no one in the population has 0 symptoms of really any condition, right? So 0, we all have some level of symptomatology related to autism spectrum disorder. There is no normal, right? Some of us are inflexible in thinking. Some of us have sensory processing atypicalities. Some of us have strong and stereotyped interests that are, spouses or partners find strange about us, right? So all of those things, there's a whole lot of normal essentially, right? And at the end of the day, there is no normal, right? We all have some traits. And then we have percentage of population. And our goal as a neuropsychologist is to kind of understand kind of that normal curve that occurs and when symptoms hit a threshold of where there is things can be impactful, right? Things get in the way of someone's day-to-day functioning. And so, our goal here is to really kind of make that determination of many of us, with symptoms, kind of they fall within this region here, which is still considered neurotypical. But then sometimes we develop symptoms that reach kind of this diagnostic threshold where a diagnosis is helpful because it impacts, it gets in the way of our functioning or it causes functional impairment. And our goal as neuropsychologists is to determine kind of where that line is. All right. So what areas do we assess? Let me just check time really quick, see how we're doing. Looks like we are pretty good here. All right. So what areas do we assess? So when I meet with families, I really explain this process on the back end, well, on the front end of the neuropsych process and on the back end of the process of trying to help them kind of understand and conceptualize what the hell did your loved one just go through for 6 hours, right? And what is this? What are all these numbers? What does the data mean? And how did you come to these determinations of overall clinical impressions and recommendations? So I present this as thinking of their loved one's functioning as like a house. I'm like, okay, so I don't want to dehumanize or be insensitive to your loved one, but think of their functioning, not them. Think of their functioning as like a house, right? And you come to me and you say, hey, neuropsychologist, I have concerns about executive functioning. I have concerns about reading. And I have concerns about kind of these psychiatric things that are going on. And I think of those areas as like the walls and the roof of a house, right? So if we kind of think of this here, this is kind of these areas here, right? So we got the walls and the roof of the house. So you can think of this as like, someone's executive functioning and academic abilities and maybe emotional or social functioning as another side of the wall. And I say to them, I see what you're saying. But the first thing that I want to do as a neuropsychologist is I actually want to get into the basement of the house and look at what are those things built upon? What are the foundation? What's the foundation of that house? That's the first thing that I do to identify any strengths and vulnerabilities that may destabilize or strengthen kind of the walls and the roof essentially. All right, so you can kind of think of this as the foundation of the house here as like, there's really four cornerstones of your thinking abilities of cognition. It's your brain's ability to utilize and understand language, which is governed by your temporal lobes of your brain. There's your nonverbal or visual spatial abilities, which is governed by kind of your parietal lobes there. So essentially what that is your brain's ability to kind of think in pictures, right? Do things like puzzles, as I mentioned before, to see how objects are related to one another in space, identify patterns among shapes, things like that. So the third cornerstone is working memory. So your brain's ability to hold on to information and to produce the result. So if I give you a phone number right now, 10 seconds, 15 seconds later, I say, hey, what was that phone number? You are using your working memory to hold on to that information. And then it's upside down here, but processing speed. So this is really how quickly and efficiently your brain can process information. So we can think about, for those of us in the room that remember, kind of the old AOL dial-up when we had to download stuff, right? And how long that took versus what we have today, right? And that's kind of the processing speed. And so my goal as a neuropsychologist really is to get in and to look at the foundation, look at those four cornerstones and see if there's any strengths or any vulnerabilities there that can give us some explanation in terms of what's going on. Okay. And then, with neuropsychological assessments, we can, as I mentioned before, we can kind of look at each of these different areas of academics and language-based functions. So reading, spelling, math, written expression, expressive and receptive language skills, word retrieval, and fluency. All of those things are really important for many of our folks in school. And sometimes I'm having a lot of discussions around that with the treatment team and so forth. They're like, why do we need to review academics? And I'm like, well, Johnny's going to go back to school at X date, right? And we need to make sure that their academic abilities are where they should be, or they may need some supports, right? Or in folks in college settings too, if there's a significant reading comprehension challenge, and this individual has a goal of getting back to college and maybe, let's say, going to law school, and we have identified a reading comprehension difficulty, that's really important for us to know and for the patient to know and their families to know so that we can support them as much as possible. We can accommodate the vulnerability and that patient can make an informed decision about their goals in school, right? Um, right. And we talked about kind of the nonverbal visual spatial abilities that we can assess with neuropsych testing and all of the information processing abilities, which essentially is like your visual memory, your verbal narrative memory, your rote narrative or rote memory. The difference there essentially is like, can you encode, learn, freely retrieve, pull it out at a later time, and recognize with cues a story, right? Rote verbal memory, you can kind of think of like a grocery list, right? Do you have apples, bananas, all of those things and your ability to kind of memorize those things. And as you can imagine, this is important for both elementary, middle school, high school, and college years and the workplace. If you're a student that's sitting in a classroom with 23 other kids and you have a lecture and you have big deficits, let's say, within your narrative memory or rote verbal memory, that impacts your ability to access the curriculum when you're a kid in school or middle school or high school or young adult. And when you're having difficulties in accessing curriculum, that is going to cause stress. And if we go all the way back to that stress diathesis model, that's not good for That's not good for our patients, right? We want to mitigate that as much as possible, and neuropsych testing can be helpful to that end. So we talked about kind of neuropsych testing obviously can assess for those executive functioning abilities that are governed by the frontal lobes of your brain, kind of the CEO of who we are, right? And your social and behavioral abilities. So social pragmatics, picking up on social cues, nonverbal means of social communication, behavior regulation, task avoidance, school refusal, etc. All right, so I'm going to breeze through emotional functioning. So things that we also can assess, within neuropsych testing: frustration tolerance, anxiety, depression, reasons or etiology of school refusal, really kind of the whole gamut. And as many of we use all of neuropsych testing is standardized assessments. We are comparing an individual's performance to their age mates. So if we're seeing an 18-year-old, 18-year, 7-month-old individual, we are comparing that 18-year, 7-month-old individual to the normative data, right? The normative data behind where should 18-month-olds, 7-month-olds be performing in particular areas: reading, writing, cognition, verbal abilities, and so forth, right? Right. We often kind of think of, if you come across a report, big picture essentially is really kind of understanding what scores mean. So if one of your patients comes in with a neuropsych report, you're looking at the neuropsych report and you're looking at the numbers, right? And let's say you're looking at their WAIS, which is the Adult Intelligence Scale, right? It's kind of our gold standard for assessing IQ. And you're seeing that IQ is a 87, right? And you're like, what does that even mean? Well, going back to your stats class 101 here, is that all of these assessments are going to report standard scores. And really, we want a performance falling between a 90 to 109, if not above. 90 to 109 would suggest it's falling on par with age mates. Anything below that would suggest that it's falling below expected levels, right? Some tests report scaled scores and T-scores, really kind of the same concept, just a little bit of a different rubric of what is considered within normal limits. So 8 to 12 is considered within normal limits, 43 to 56 considered within normal limits. All right. So if I go in or if I have a patient that comes in and let's say their cognitive abilities, their overall estimate of IQ, let's say it was a 102, but let's say their mathematical abilities is a 79. And they're not getting any supports within the school district, or the school district is just providing social emotional supports, right? Because there's been a hospitalization, there's been a lot of social emotional challenges identified. Right off the bat, what I am doing as that individual starts to think about reintegrating back into the school setting, I am already designing a treatment plan that informs certainly formal services within an educational setting, such as those provided by an individual education program or an IEP, and in making sure that that individual gets the supports that they need so we can mitigate stress for them as they reintegrate. Okay, so I'm just going to we're going to go through just a case study, and then I promise you we're going to get into the details of different things that we can look at, what the services look like within a school setting, or what they could look like, workplace setting, and so forth. So this is a pseudonym here. So this is obviously de-identified, just so everyone knows, but this is a patient that I saw. We're going to look at actually real data. So this was a 22-year, 4-month-old right-handed monolingual Caucasian male, referred for a comprehensive neuropsych reevaluation by a psychiatrist in our program, Dr. Tyson. So this patient had prior diagnoses of schizophrenia and a specific learning disorder of impairments of reading, more specifically dyslexia, which was received at age 9. And really, after this patient experienced several episodes and breakthrough episodes as well of psychosis with multiple hospitalizations, the overall goal was to see, let's get an updated assessment of neurocognitive functions and learning so that we can help this individual with treatment, educational planning, because he had at that time at 22, after spending some time away from school in any sort of educational setting, decided he wanted to go back and pursue that as a goal. So this may mean everything, or this may mean nothing to you, but this is what a battery would look like. So this includes tests of, cognitive functions and academic functioning, language. This is phonological processing, which is a skill set that is at the crux of dyslexia. Visual motor integration, and then a whole array of executive functions and adaptive functioning measures that the patient fills out, or their parents or caregivers fill out. If you were to look at this battery and you did not work in the specific field that we work in, the specialty field of psychosis, you would not be shocked by this battery. This is not anything that's groundbreaking in how we develop the batteries for our patients. I think oftentimes when trainees come in, or neuropsychologists that are colleagues of mine that we work with, I think there's this kind of presumption that the neuropsych testing is going to look drastically different, because I think there's this, I don't know if it's on some level stigmatization. I think on the other level, it's that our field in particular, I think we're still kind of in the nascency of really developing professionals' understanding of what psychosis is and what it is not, more importantly. And so, working with some colleagues who don't work in our specialty field, they ask me, like, well, what does your battery look like? Is it so much different than what I do? And it's really not. This is kind of really, many of these tests are kind of what we would give in a general neuropsychological practice and so forth. It's just maybe the application and interpretations of things can be a little bit different. Okay, so remember, this is our 22-year-old, experienced multiple episodes, including some breakthrough episodes, breakthrough medications, multiple hospitalizations. And the goal of this testing was to get an update on neurocognitive functions. Here's the foundation of the house, if you will: verbal, nonverbal working memory, processing speed, and some overall estimates of cognitive functioning, or IQ. We fortunately had data from 2013. When I saw him, I believe it was like 2021, something along those lines, something like that. And you can see kind of in 2013, this is a young man that was, we looked at the foundation of the house, right? This wasn't me. This was kind of the school district actually that did this testing. You can see that many of his abilities were falling at, if not above, expected levels, with the exception of processing speed. So he had pre-morbid, pre-existing processing speed weaknesses. This 2013 time point, excuse me, um, was a time point in which he had not experienced psychosis yet, right? There were no kind of psychiatric things going on for him at that time. There was just a learning disability that had been identified. When he was reevaluated within in 2021 at the age of 22, you can see the clear differences, right, between those performances. This really speaks to he's working with a different brain after experiencing that much psychosis, if you will. It speaks to the insult to the brain, right? And so these are some really, while he had some clear relative strengths, these create some obstacles for him when it comes to, when it comes to his goals. And so I'm going to show you kind of his academic performances too. And what we can see is, remember, we want these standard scores falling between a 90 to 109, which would be considered within normal limits for him at the age of 22. We can see that his word reading abilities are far below that in the first percentile. He had some writing abilities that were pretty well developed. His math abilities look pretty good. These are tests of how quickly and efficiently he can read and write and complete math problems. We can see that efficiency, things that are under time constraints, are really, really challenging for him. And then this Nelson-Denny test kind of mimics standardized testing, mimics kind of like the SAT essentially of, you're reading a passage, you have a Scantron bubble sheet, and you're kind of filling that in. And, kind of in one, it's a great test of your reading comprehension with dense passages. It also kind of mimics standardized testing, which in my opinion, kind of qualitatively is a nice thing because I don't know for anyone else in the room, but standardized testing causes me a little bit of anxiety. And so it gives us kind of a sense of like how someone approaches this, what this is going to look like in real time. And we can see that these are marked deficits, right? 20 years ago in the field of neuropsychology, the neuropsychologist would have sat down with Chris, again, a pseudonym, and said, hey, given this score, given these scores and given this, college ain't for you, buddy. You should do something else, right? But we've learned from that, and we are no longer what we don't test in neuropsychology is someone's gumption and resilience, right? This young man said, I want to go to college. And we looked at his scores and reviewed them, and we said, hey, you got some obstacles, buddy, but we're going to like pump accommodations. Let's get you some tutoring. Let's chip away at college. You don't need to take 8 courses in a semester. Just chip away at it. That 4-year, oh, you got to do college in 4 years. That's a farce. You don't have to do that. You can do college as long as you want to do college. And this young man completed college in 6 years with this profile, and after got his bachelor's degree, and started after that started his own business as an entrepreneur with a really, really successful landscaping company, making more money than all of us neuropsychologists that he's worked with. So it's just a really, really good success story. And also, I want to just point out kind of the limitations of neuropsych testing and standardized scores, right? Of that, it gives us some information. It helps us understand kind of the nuts and bolts of how someone's brain is working. But there are many other areas that we need to consider, such as resiliency and supports, et cetera, that that can support our folks that we work with. All right, so let's get into so it's 12:24. Let's get into the school stuff. I got about 5 more slides and then some things I wanted to show you guys just from an educational standpoint. But we're going to start with so what do we do with neuropsych testing? So you get this testing, you've identified that there's, let's say, neurocognitive weaknesses or learning challenges. Your patient wants to get back into school, or your family is saying, hey, they're really stressed with school. And there doesn't have to be a leave of absence from school either, right? Is that for those of us that are working with folks who never took a leave of school, or for maybe our clinical high-risk populations who are in school, but our goal is to lower stress for them, right? School eats up 6 to 8 hours of their day, let's say. It's a big part of our young people's life, as does work. And therefore, helping them kind of get those services in play are really important. There's really two And again, I know that there's some comments coming in. We'll get to those. If there's any questions, we will absolutely get to those. Okay. Um, okay. So what can we do? We're going to start with a school standpoint. So if we're working with a patient, many of our patients are not in elementary school, but some that happens at times in our program, but mostly they're in middle school, high school, college, right? And there are services that you can get through someone's public school district, right? So as a taxpayer in a town, let's say, I'm going to say New York City, right? Let's say Manhattan, right? As a taxpayer there, I have rights. And the rights essentially are that there are federal laws, uh, which is called the FAPE, which is Free Appropriate Public Education, right? And what that means is that if I have a learning difference, then I need to get a free, appropriate public education, and I need to get that. I need to be able to learn because of that law. And there's another law that comes in and protects those with disabilities, and that's the IDEA, right? So essentially, the IDEA is the Individuals Disabilities Education Act, which is a law that says if someone has an identified learning disability or some other disability, can be an emotional disability, is that by law, I have rights to get services, right? And so that's where you can go to your town, your school district in your town and say, hey, our son, daughter has been identified with this. We would like to get some formal services in play for them. There's two things that we can have going on. We can have a 504 plan, or we can have an individualized education plan. Those are two different things. We can kind of think of them as tiered a little bit. The 504 plan, as you can see, they're governed by different types of laws and departments. But this is if someone has a disability that significantly impacts a major life function. A 504 plan really is for accommodations and modifications to curriculum. So extra time, taking tests in a separate setting, giving someone only the odd problems, right? Making sure that they don't take more than one test in a given day. So this is a 504 plan. It's for school, work, and college. And 504 plans can transfer to the college setting through the Office of Disability. The 504 plan has less legal weight behind it, in my opinion. So if a district agrees to a 504 plan, what they're saying is that we see that there's a medical thing going on. We see that your child needs some accommodations and modifications, like extra time to put down on paper what they know and to keep stress low. And the district says, we'll agree to this 504 plan, right? But they are the implementation of a 504 plan, as you can see, is that there's not a whole lot of intervention there. It's more like molding the environment to the medical condition or whatever's going on for that individual so that they can kind of perform to their kind of potential or at grade level. The IEP is a stronger kind of set of services, a stronger legal agreement with the district, essentially. The IEP is governed by the Department of Education, and the requirements are that the individual has a disability that meets criteria under this particular law. It significantly impacts educational performances and it requires special services. So this can include everything from like getting reading interventions and specific reading interventions. So for those with dyslexia, there's a reading intervention called Orton Gillingham or the Wilson Reading Program. Speech and language therapy, occupational therapy, access to a school psychologist, all the way from these kind of individual services to an IEP can dictate, well, if a district, let's say, doesn't have like a therapeutic program, meaning that it's not a classroom or MILU that has a school psychologist with kind of CBT training and access to kind of these interventions, and it's a small student teacher ratio. Let's say a district doesn't have that. What that district could do is say, hey, student A and family A, we don't have that, but there is a private setting that does have all that stuff and does it really well. One in our areas like New England Academy, let's say, right? And that district may agree to say, you know what, student, actually, we can't serve you And if we tried to, it'd be a violation of this because we don't have the services in play. And so therefore, we're going to agree to put you there. Now, I did that in a way that's way more cordial than it usually plays out, right? So districts to do that, to send someone to New England Academy, that's $60,000 a year, right? And that is the district is accountable to pay for that because of these rights that are in play. And therefore, I am not necessarily cynical here, but those conversations, as you can imagine, given the financial kind of obligations that are involved, those conversations are longer conversations that go all the way, that either take a longer extended time to negotiate around and provide the data around, to all the way to where they go to mediation within the state, where a mediator and the family and the district and attorneys, and it gets and can get a little nasty there. Okay. One of the important things or interesting or maybe things to note for our patients is that individuals can also be under an IEP until the age of 22, which is great for a lot of our folks because what we understand or how we understand this illness is that many times psychosis is going to present itself at a later stage and it's different between males and females, right? But if psychosis presents itself in, let's say, when someone is 17 years old in their junior or senior year in high school, and that year's a wash, and we identify kind of all these challenges, we can go to the district and we can say, hey, this individual is not ready for the next step, right? We need kind of what we call transition planning. And transition planning is like, let us help you become an adult, right? Let us help you with an independence. Let us help you, give you more time to get maybe some reading interventions for you to get kind of more stabilized from a psychiatric standpoint. Let us help you with college, like liaison work, executive functioning, adaptive functioning, like independent skills, all of that. And we can convince a district and say, let's delay that diploma. We're not ready to graduate in June here. We want another year under that IEP. And then after that year, we're going to see where we're at. And we're going to have another discussion. And we may say, all right, we're ready to roll. We're ready to kind of, let's get our diploma and then let's make a decision about next steps in life. Or we may say after that year, we need another year, right? We had another relapse, let's say, and we want more intervention around the adaptive functioning, executive functioning skill sets, et cetera. And so just to kind of keep note of that for some of the folks, that is something that is available and out there. Okay. IEPs go through grade 12 once you, but as I said, they can be extended till the age of 22, where folks can kind of delay receipt of their diploma. Importantly, this is one thing that always is a question, like patients of mine will say, whoa, 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 whoa. I just put in all that work. All of my friends are going to be walking at graduation and getting a diploma, and I'm going to be sitting in the stands or not going. I don't want to do that. And so a little note here is that what they do is they still allow that individual to walk and to go through the ceremony process. They get something that looks like a diploma when they go up there, but it's not. But they go through that whole process where it is not kind of this stark, difference in kind of planning for that individual. So it is something that works out pretty well, where they go through that whole thing with their friends, and then we discuss with them around disclosure about next steps and so forth. Okay. So, and then what we can do with each of these, a 504 plan and an IEP, is that we can go to a college. If someone decides to go to college after going through this whole thing, we can go to that college, go to their Office of Disability. This is where Martha comes in and is an absolute pit bull and goes in there and says, hey, listen, like, these are the things that this individual needs. What do you have available? The Office of Disability works with our patients and Martha and the family and helps that individual do things and get various kind of supports and accommodations. Things like being able to tape record lectures, getting tutoring, also things of the nature of like taking one course, but still being considered a full-time student, right? So that there's no impact on financial aid or scholarships and so forth because of this disability. And or separate dorm room, right? Things like that are all the various things that colleges, there's a whole array of things that they can help individuals with. one of the things that I really love and my patients really love is that in college, they have this service, which I would have loved as a college student. These, the really like annoying, smart, organized people that go into their college courses and take these like beautiful notes, and it's like so cohesive and makes sense. And, I had those friends in college. It definitely wasn't me, but they hire those students to go into courses and to take those notes, and they give those to our folks that we work with, and it's mind blowing. It's such like a beautiful thing, man, and it really helps a lot of our patients because they can actually just sit in on a class and like enjoy the lecture and try to soak in the information and not be worried about doing the multitasking that comes with taking notes and all of that. So, okay. So I've probably talked way too much here. Let's see. I just want to take a look at what I got left. Okay. Yeah, so I'm going to send the slides out. We're not going to go through each and every one of these here, but I'm going to send these slides out. I'll also send an article that we wrote, school-based approaches for psychosis, which this comes from. And so these are helpful services and accommodations for primary and secondary school. These are direct service accommodations for college settings. And there's also in the article that I'll send out, there's also kind of workplace accommodations. So things like essentially what we do in neuropsych testing is we say, that it's medically necessary for this individual to get breaks, for this individual to have flexibility around deadlines, for them to have kind of things in, sometimes what we have is, have their duties and tasks kind of written down for them, that they have a point person on the job. And so there's a lot of kind of job coaching accommodations and things that we do for folks in the workplace. And I'll offer up Martha too. Sorry, Martha, but Martha is always amazing in terms of curbsiding with folks, and she's fantastic with the workplace stuff, and I'm sure would be happy to chat with anyone offline about different things that she's done from a job coaching standpoint. Okay. So let's see how this is going to work here. So I'm just going to show you, I'm going to take 3 minutes and then we'll have 20 minutes to answer any questions and so forth. I am just going to show you the DESE, or the Department of Education in Massachusetts, kind of what the IEP process looks like and how families can navigate this, okay? I want to, how is this going to work here? Just going to pull this up. Skip verification. Can you all see what I'm seeing, the DESE website?
I don't, we're still seeing your slides.
Okay, all right, let's do this. Okay. Let's see here. All right, everyone, bear with me here. Okay, so what I'm going to do is I'm going to take us to the DESE website, and we are going to look at what the eligibility process looks like very quickly. We're going to look at an IEP and what are the major points that you should look at in an IEP of like, look at this area, look that area, look that area. And then what else did I have on there? Let's see. And then I'm actually going to show you a good place to go to where you can send your families to that shows them kind of, how to write a letter to the school district. It's a template they can use that says, this X, Y, and Z has happened. We're concerned about this, and we would like to initiate the process of getting some of these services in place. So I'll show you where that's at. And you can share that with families, and I think families find that pretty helpful. Okay, can you see the DESE website now?
Yep, yeah, showing up.
Great. Okay. All right. So what I'm going to show you is, when families sit in on an IEP meeting, they sit with the school district team, the special education team, and they have this form in front of them. This is after the testing takes place, right? And everyone sits down and discusses strengths and weaknesses and impressions and recommendations and so forth. And so what they do is they essentially follow this flow chart, right? And for our folks, let's say it's an individual with who has experienced a psychotic break, and they also have identified, let's say, some learning challenges, right? And so, they kind of go through this catwalk after probably an hour of discussion, said, okay, let's go through the eligibility criteria, right? And so they go through this with the family and the patient, depending on the age. Does the student have one or more than one disability, right? If yes, indicate the disability. So we would say emotional disorder, let's say in specific learning disorder. And the answer is yes, right? So we go through here. If it was no, obviously the student is not eligible for special education services and the meeting ends. If it's yes, if the student has multiple disability types, please check the box to indicate the primary disability, right? So we would indicate whatever primary disability is at the point. Usually for our folks, it's this here. And then we go to this next catwalk right here. Is the student making effective progress in the general education population? In the case of the 3-year evaluation, would the student continue to make effective progress? So that is referencing that once someone gets on an IEP, every 3 years, they get a reevaluation and determination, okay? So once someone's on IEP, they're going to get a reevaluation determination in 3 years. Annually, every year, once someone's on IEP, you meet with your school team and you make a determination about, it's not an eligibility determination. It's a determination about what the services should continue or not continue to look like. Okay. So are they making effective progress? If yes, the student is not eligible, right? Oftentimes we're advocating for no. Well, they're not making effective progress because there was a hospitalization. They haven't been back to school since. We're concerned about their grades, et cetera. And then you go through this kind of catwalk where the student is hopefully finally deemed eligible for services. Okay. So that's kind of the beginning of this whole conversation. And now I'm going to show you. Go back to what did I have next there? Okay, so this is right. Let me do this. Sorry, guys. Give me a moment. Okay, great. Yes, 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 yes. Okay, don't switch. All right. So now I'm going to show you what an IEP looks like. And for those of you that are well aware of this, I'm sorry if this is fundamental to you here. But this is kind of what an IEP would look like. This is a de-identified IEP that Tewksbury Public Schools had on their website. So please don't be concerned about that. So essentially, this is the demographic information, right? This talks about the student and team's vision. This talks about on this page here is lists the disability. So if you get an IEP, you can kind of look at which disability is indicated there. You can one of the key points. So these are the goals. These are the discussions about how a student's disability impacts their involvement or progresses. But for the sake of time, I'm just going to scroll down and I'm going to show you very quickly about areas to have a look through. Okay. So usually it's on the back end of the IEP. What is this? This has page 13. That sounds about right. And so you're going to see this grid essentially. And this grid really talks within this grid, there's there's 3 grids essentially. There's a grid that discusses, are there any consultation services that this student needs? So this could be like, yes, we need a consultation with a speech and language pathologist to support their math curriculum, given that there's a language deficit, right? or we need a consultation with the school psychologist, right? Or we need a consultation, and this is an ongoing consultation that provides consultation to teachers and staff and administration about the student, but it also provides consultation to the student and to the family. This grid B here is our services that they are direct services. So these are not accommodations like extra time. These are direct services that they're working one-to-one with a staff member or provider. But within this B grid, you can see that these are direct services that are occurring within a classroom or within a general education classroom. So this could be a reading specialist going into working with our patient within their classroom. So pulling them aside within the classroom, working on things like reading comprehension. So that's kind of a tier that is above the 504 accommodation. It's actually a direct service, but it's happening within the classroom. And then grid C is kind of the tier above that, where this is what's called a pull-out service, right? So this is a direct service where our patient or the student is pulled out of the classroom. They are taken to a separate room and they are working with, let's say, a speech and language pathologist or reading specialist or math specialist or executive functioning coach and things like that. So those are kind of, that's a key area that you can look at. And then lastly is, well, this page doesn't have it, but lastly, there's a page that talks about placement, whether placement's going to happen, where a student is going to be enrolled. Is it going to be in a general education classroom? Is it going to be somewhat general education classroom and then a substantially separate setting? And based on the percentage of how much time they're in the general ed classroom versus the setting, then they are considered whether they're inclusion, partial inclusion, full inclusion, or as we talked about, kind of a substantially separate classroom or placement. Okay. All right, so we have 13 minutes. I'm sorry I talked longer than what I wanted, but I know that there are a lot of questions posted here.
So, do you mind? I raised my hand. I put the first question. So,
yes, sure. Yes, yes, by all means, yes.
My name is Jerome Taylor. I'm a child and adult psychiatrist and direct the Children's Hospital of Philadelphia First Episode Psychosis Program. Great. And this is a great presentation. And Dr. Apurva Bhatt is also a child and adult psychiatrist at Stanford. I love her. We both love your quote. You can't measure gumption or resilience on kind of standardized testing.
Oh, great. Thank you. Yes.
I guess one of the things that I do in our program is we refer, usually cognitive testing actually comes with IEP, like IEPs in general. But the question is, what is the difference between, like, when should I refer someone for cognitive testing versus neuropsychological testing? I put a link to a kind of a PubMed paper there because from what I understand, that so you become a PhD, clinical psychologist, then you can do IQ testing, but like neuropsychological testing, you have to do another year of fellowship, and it's usually more in depth. But even in the fields, like when I was reading different things, people use those interchangeably. And I know as a psychiatrist, we are not taught the difference between that. And so, yeah, do you have insight? That's the question. And then the other question is just, people have baseline, which is related to your sort. People have a baseline IQ and they develop schizophrenia. Like if you measure it like 3 years, like before and after the onset, do people like get back to that? I usually say they don't usually get fully back, but just, I don't know. That's the other question.
Great questions. Great questions. So the way in which I think of neuropsychological testing and the difference between cognitive testing, right? You're absolutely right. So let's say you go to a 4-year PhD or 5-year PhD program, right? You get a clinical psychology degree and you learn how to administer cognitive testing. So that cognitive testing would be the Wechsler test, let's say, right? So the WISC, and for our adult population is the WACE. And so you are able to administer that testing and you're able to interpret it and write that out. I think that is one key and critical component that falls under the whole process of neuropsych testing. Neuropsychological testing is taking that key critical component, which we do within neuropsych testing, but it's integrating that with all the other information that we have, such
But
as
they do
like,
that too. Like, so they do that too, and they will cut that. Like she because we have a PhD psychologist who evaluates autism as a part of our program. Like
yeah,
she does IQ testing and academic testing and function, and she says that Jerome, that's not neuropsychological testing. That's cognitive testing. That's just standard for her. But like I was like, no, I think that's neuropsychological testing. And like so functioning, academic achievement, all the interventions
yeah,
like she calls that just regular, I mean, she like cognitive testing, and which interventions, but like and at CHOP specifically, they only do neuropsychological testing if you've had like a traumatic brain injury or like
yeah.
it's and I guess
I
and the reason it matters is because honestly, I have a patient now, and she like is asking for neuro. I don't know. Anyway, so if maybe there's not a big difference, and yeah,
no, no, I hear you on this. I think it's a lot of semantics, honestly, within the field. And I think if we think about, there are neuropsychologists, right? I call myself a neuropsychologist. I think there are neuropsychologists that would say, like, well, that's not actually neuropsychology because you're not studying like stroke or brain injury, and we're not associating that within the report to like there was an insult to the frontal lobe of the brain at this particular area. For
and the
me,
wait lists are different, which is why it matters. Like wait lists for neuropsychological testing is even longer than cognitive. But go ahead, sorry, yeah.
you got it though. But in those, and as you can imagine, those neuropsychologists, right, are very integrated into neurology kind of departments and so forth, right? And while those can be incredibly informative and helpful and to identify focal points of the brain that have been impacted, which helps the whole treatment team to kind of figure out what area is impacted by that stroke, right? What area is not functioning as it used to be functioning. I think for the difference maybe with your colleague that calls it cognitive testing, and I don't disagree with her. I think maybe we should do that more often, right? But is that it's the integration of that, and we make it these reports, let's say, right, are more practical for our patients in their day-to-day lives versus kind of saying to a family, hey, this was the insult is into the parietal lobe, because we're not necessarily kind of identifying that or associating that within the report as we work with our patients. But I really think that if you put myself in a, like, let's say a neuropsychologist that is ABAP neuropsychology trained and works with the Department of Neurology, they would definitely say like, well, I'm not really sure that I would call what you're doing neuropsychology, right? But I think it's semantics and there's differences in the field. So, but we all get along usually. We all get along.
No, yeah, I just thank you for that makes me feel better. I mean,
Yeah.
but in terms of I'm not, but the wait list at CHOP is so long for neuropsych, and they won't even. And lots of psychiatrists didn't realize this, and she was like, "Oh, I can do a cognitive test for you, like if that's all you want," or like, and I was like, "That's what I want." But so that
I,
I'm venting. But the second
I
question is, what?
No, I do think, but again, I think it's semantics because if someone came to me and said I want cognitive testing, I would think like, okay, you just want cognitive testing. You want me to deliver a
Exactly.
test of cognition, which would include test of intelligence. It may include other cognitive functions like verbal fluency or memory and things like that, but I would not think of kind of the whole broad kind of spectrum of neuropsychology with that. So I do think it's semantics and difference in training and so forth. So
But the other question was whether or not people get back to their full functioning. I don't want to like, or do they like some do, some don't. If you start out really high, like an IQ of 130, then you go down to 120, you can still achieve a lot. But I guess that's my question. Like I've seen it across the
yeah.
board, but I don't know what the science says about it. Or
Yeah. So it's just what you said there, right? And as you would expect with like many of our other medical conditions that we work with, is that there are some folks that will get back to their baseline, right? Their baseline level of functioning. There are some folks that go a little bit below, and there are some folks that go far below and sometimes even continue to go below, right? There's kind of almost this degenerative effect, if you will. And we oftentimes are discussing with our patients and their families like and this is with really kind of I think all aspects of the care that we provide is it's this really unsatisfactory kind of wait and see. Let's see where we can get things going from that standpoint. So there's a difference there.
Thank you. And the slides that they were awesome. And if you could send them out, that would be super, super helpful.
Absolutely. Yes. Thank you. Thank you for the feedback. I appreciate it.
And we have a couple of comments. I think first, just commiserating with the waitlist issue. Definitely, I think a shared experience. And then
Yeah.
one question from Patrick in the chat, though, saying, I've long struggled with finding the time to prioritize assessment of cognition, even though it's such an important prognostic indicator. Um, so if you had 1 hour with someone to get a snapshot of their cognition, what would you prioritize? Something like the WACE, or is there more specific tests that you would prioritize?
Which tests? Yeah. So if I was, if I was going to be thrown on an island and I had to pick the measures that I would want with our particular patient population, I would want, yes, the kind of the gold standard cognitive tests, and that being kind of the WISC or the WACE. What I would also throw in there is a measurement and really we only have good measurements. Well, there's some measurements that are kind of one-to-one, but the best measurements I feel like for adaptive or independent functioning, like the ABAS or the Vineland, right? And that's really based on kind of caregiver report or someone in their life report, right? Where we can get kind of a assessment of adaptive functioning. How are they doing with money management? How are they doing with navigating a bus system? Are they mindful of health and safety measures, things like that? So those two things, how many can I pick, Kelsey? Just three?
Whatever you can fit in an hour. Yeah.
Okay, okay, yes, yeah, yeah. So I would do that. I would have a report measure of adaptive functions, and then I really would I would be stuck between actually I would go with kind of the memory tasks, right? I would go with like verbal memory, which would be you could use the RAML or the WMS. And then I really like the Ray would be another one. So the Ray complex figure test, because it tells us so much information about how someone approaches the raise essentially without compromising test security is a you look at a really complex geometric design and you have to kind of recreate it, and it tells us a lot about it measures kind of your executive functioning, your multi-step kind of planning, organization, your visual spatial processing, what that looks like. We get an assessment of your visual motor integration because we look at kind of how those things are integrated. You use your perception and your fine motor control. And then it also allows us to look at, well, if you on the front end struggled with those things, how does that impact your memory of that information? And so it gives us a nice assessment of visual spatial memory, but also why. Why are you struggling to memorize that stuff? Is it the way in which you learned it, or is it kind of a true memory deficit around it? So it provides a lot of information that way.
Yeah, thank you so much. That was an awesome answer and exactly what I was looking for.
Great. Thanks, Patrick. Great question.
I think we have time for one or two more questions. And again, I just lots of great comments in the chat. I think all of this is just very practical, useful. So thank you for that. But yeah, if anyone has additional questions.
Absolutely. Yeah. And again, after today, I'd be happy to have any sort of curbside with folks about anything. And I'm gonna again offer Martha's help out too. We'd be happy to kind of talk to you about kind of how we operate and navigate situations, whether that's school district or otherwise. And I did see a lot of comments around, the wait list for neuropsychological practices. It's absurd. Like we have to do better as a field and figure that out. And I'm saying that as a neuropsychologist, right? I just don't, it's something that I think from an administrative leadership standpoint that we really need to find ways to have more access to that. The school district, obviously, you can get testing done with the school district, and that's great. But sometimes, and I'm not cynical with school districts, I know I kind of have put it that way today, but sometimes, a family and a patient needs kind of an independent, objective kind of approach, right? And to integrate that information with what the school team is seeing and not being remiss with what they are seeing, and that's not invalid, right? But to come together on like an understanding of a patient, I think is really critical. And as we know, the districts are just absolutely like under-resourced, and it's impossible for them to have a beat on 500 students and to be able to do this in a, in my opinion, like high fidelity way, and develop kind of robust treatments. And lastly, I think we can be incredibly strong advocates for our families and their patient, and our patients and their families. And I think without us advocating, stuff just doesn't get done sometimes, right? And for various reasons. So.
Yeah, thank you. I think that is a great note to end on. So appreciate everyone stopping by today. Happy Friday, and have a great rest of your day. Thanks.
Thanks so much. Have a great weekend.
Thank you.
All right.
Bye.
Bye.